Now. I want to welcome you all to Our Community, Our Health, which is a town hall series that shares ideas and facilitates a two-way conversation between the community and researchers. Today is World Asthma Day, so our discussion is going to focus on pediatric asthma care. I'm Dr. Jen Fishe. I'll be your co-moderator for this afternoon. I'm an assistant professor of emergency medicine and associate medical director of the UFHealth Jacksonville Pediatric ED. Before we start, I want to show how you can become engaged in the conversation through this webinar. So there's a Q&A button at the bottom of your screen. You can click that button and send in your questions and comments throughout the town hall. Myself and the other panelists will be monitoring the questions, and we'll read them out either interspersed through the webinar or during dedicated Q&A time after we all have spoken. I'd like to briefly introduce our panelists who represent diverse clinical and research backgrounds. You'll hear more about their backgrounds in depth before each of them has a chance to introduce themselves and speak about their wonderful work. I'm joined by Dr. Sreekala Prabhakaran, Dr. David Fedele, and Dr. Kathryn Blake. So why are we here? Why are we interested in asthma? So myself, I'm clinically a pediatric emergency medicine physician, meaning that I work in the ER exclusively taking care of children. I'm also an asthma researcher and a pediatric EMS medical director, meaning I help EMS agencies and ambulance companies deliver the most up-to-date care to children with all kinds of emergency conditions. But what makes asthma so special? Well, asthma is the most common chronic disease of childhood. There's about 7 million children in America today who suffer from asthma. And on average, each one of them experiences at least one asthma attack per year. During that asthma attack, those children have trouble breathing, trouble exercising, going to school, doing their everyday activities, and even sometimes they have to go to the hospital or the doctor's office. And in fact, there are 2 million emergency room visits each year due to children with asthma attacks and over 150,000 hospitalizations annually. There's also a social cost to childhood asthma for caregivers and the families and kids themselves. So for example, there's at least 10.5 million missed school days per year because of asthma and asthma attacks. And that's not even counting missed days of work for parents and caregivers as well. So as you can see on your screen, asthma affects children of all ages, all races, all ethnicities. It affects kids who live in cities, who live in suburbs, and who live in rural towns alike. And the goal of asthma care is to control symptoms so children and their families can get back to enjoying life and having fun being kids. But it's important to know that asthma doesn't affect all children in the same way. So we're here today to talk to you about new and updated treatment options, emergency care options, and exciting research that needs community participation in order to better help kids with asthma feel better faster and getting back to being kids. So for myself, being an emergency physician, timing and acting quickly is everything. So once a child has trouble breathing due to an asthma attack, myself clinically, I think, well, they need what we call an inhaled bronchodilator. And you all, if you have asthma or have a loved one with asthma, probably recognize the images on the screen with an inhaler or a nebulizer. And the medication contained in that opens up the lungs. In an asthma attack, the lungs are constricting, the airways are getting smaller, and this vicious cycle of small airways inflammation is starting. And by delivering medications like albuterol through either an inhaler or a nebulizer, we can help stop this cycle of the lungs clamping down and constricting. And as always, in emergency care, the faster, the better. However, the most widely used medicine for this hasn't really changed very much since about 1970. So we've been essentially using pretty much the same medicine for about 50 years. But we do notice clinically that not every child responds to this medication in exactly the same way. We know in the ER, some children turn around right away. They get one puff of their inhaler and they're ready to go back off playing on the football field. And then there are other children who can get several treatments and they're only getting worse and they're not getting better. And so we're just beginning to understand that clinically different children respond differently to inhaled bronchodilators, but that there's also a genetic component of this as well. And we can perhaps use genetic sequencing, so learning about our own genes, to predict and know ahead of time who will respond well to these medications and who might need extra medications to help them feel better. And so I'm very excited that we're doing a study of this at University of Florida in partnership with Nemours and some other people, including Dr. Blake on this panel. where children who come into our pediatric emergency department with an asthma attack, we measure their response to the medications, and then we're also doing genetic sequencing. And we've recently found 3 genes that help us predict whether children respond very well, sort of middle of the road response, or don't respond as well to this sort of first line medication for asthma attacks. And so you can see that here. We have groups of kids who respond very well. This is in the gray bars. We have kids who have a pretty moderate response, and those are in the green. And then we have children for whom you can see in the orange, this medication really doesn't do much of anything at all. And we need to be more proactive with them and get them other medications to stop their asthma attack. Now, if you have asthma or someone you love has asthma, you've probably heard of albuterol and inhalers and nebulizers. And you've also probably heard the term steroids as well. So in the emergency department, when someone has an asthma attack, we want to get them those breathing treatments, but we also want to get them steroids as soon as possible too. And that's because steroids can help combat that inflammation that is taking over in the lungs. And like with albuterol, the quicker the better. And so I have some examples of different steroids here. Now, I mentioned in my introduction that I help EMS agencies with their protocols to take better care of kids. And so for children who are having such trouble breathing that someone calls 911 and an ambulance comes to treat them and take them to the ED, there's a unique opportunity to give some very time-sensitive medications before a child could even arrive at the emergency department. And so a few years back, I did some research and found that most ambulance companies in Florida and nationwide will give children albuterol and inhaled medications. However, most ambulances were not giving children steroids. And the ones that were giving IV steroids. Now, no one wants to put an IV in a child if they don't have to. We want to avoid painful procedures in children if at all possible. So there are plenty of oral steroid options as well. And this is kind of a unique hybrid study that we're also doing at University of Florida right now, where we're changing clinical care on the ground while we also look and see from a research perspective how it's changing outcomes. So we've partnered with 5 EMS agencies in Florida, as well as 2 EMS agencies nationwide outside of Florida to add an oral steroid option to the ambulance protocols for kids who with asthma attacks. So now these children are getting steroids anywhere from 30 minutes to an hour faster. And we're seeing whether this decreases the number of children who have to stay overnight in the hospital due to an asthma attack. And we're also seeing whether it means that these children can be discharged home from the emergency department faster. Now, while this study is still in progress, the end goal of this is optimizing emergency care for each individual child, because we know from what I was talking about earlier that no kid is alike. So we're hoping to build a medication map for ambulance companies. So providers using a smartphone could look at a map and say, okay, I'm this far from the hospital, I'm in the red zone. I'm super close, maybe I don't need to give steroids. Or I'm in the green zone, I'm really far from the closest hospital, maybe 45 minutes away in some cases. I absolutely need to take the time to give this child steroids so that they have a better chance of going home and not being admitted to the hospital. All right. So that is some of the exciting work that I'm very privileged to do. And with that, I will introduce our next panelist to talk about her wonderful work. So Dr. Sreekala Prabhakaran is a pediatric pulmonologist in the Department of Pediatrics at University of Florida. She's board certified in pediatric pulmonary and sleep medicine and is the interim chief of the pediatric pulmonary division with a special interest in children with severe asthma. Today, she's going to discuss her partnership with school nurses to improve asthma outcomes in children.
Hello, everybody. Now, we heard from Dr. Fishe, the emergency management of asthma. Now, I would like to talk about our severe asthma program and to give you guys some introduction about that. So at UFHealth, we have a severe asthma program that is purely dedicated to patients with severe, or I would say, difficult to control asthma. Late 2015, early 2016, several like-minded people, a pulmonologist as myself, a nurse practitioner, Dawn Baker, a clinical pharmacist, Dr. Leslie Hendless, a nurse and asthma educator, Alicia Hardy. We all got together and started the severe asthma program. And we are seeing patients, severe asthma patients on Friday morning in the Med Plaza clinic. In this clinic, in order to give them the right treatment, we identify different barriers that these patients and family are going through. We coordinate and implement the right treatment for this high-risk, life-threatening asthmatic patients. We provide specialized diagnostic and personalized therapeutic approach for these patients. We learned that asthma education is the key in order for these patients to have better management. We use special resources for these asthma patients and started a school asthma maintenance program. In this program, we use asthma school nurses in order to give asthma maintenance medication to these high-risk patients. One of the main reasons for poorly controlled asthma is because of non-adherence to medications, the maintenance medication. So asthma airways, if you look this asthma airway, you can see how much airway inflammation is happening in this airways. So there is a baseline airway inflammation happening in asthma. That is the reason, just like Dr. Fishe was talking about how important you give that inhale, the systemic corticosteroid for patients with asthma in order to calm down that inflammation. These patients need maintenance asthma medication, that is inhaled corticosteroid, to calm down that inflammation. If that we don't take care of, when there is a small trigger comes into their airway, a severe asthma exacerbation starts. So in order for them to have good asthma control, we started a school maintenance asthma program for these patients, this difficult to control asthma patients. What do they do is, like, when they come to the school, the first dose of inhaled corticosteroid they get from the school nurses. Before they go back from school, they get the second dose. At least 5 days out of 7 days, they get the asthma maintenance medication. You know, when our patients don't getting asthma well controlled, the first thing that we do is call the pharmacy and to get the refill history. And what we learned from that is they are not even picking up the prescription. If they are not picking up the prescription, they are not getting the medication. That is when we got this idea of starting this maintenance asthma medication at school. And we got really good outcome from this. And kudos to school nurses, direct observed therapy of inhaled corticosteroids for asthma at school or daycare. We got published this paper in 2018. This paper found out that starting inhaled corticosteroid or maintenance asthma medication at school gives well control of their asthma. And we found that there was significant improvement in their asthma, significant decrease in hospitalization, significant decrease in their need for emergency room visits, and even oral corticosteroid need. The new baby in the block for our asthma, severe asthma program is medico-legal partnership. Couple of nurses in the, couple of lawyers in the county, they were very interested in this program, and they partnered with us to start this medico-legal partnership. What they do is, like, they come to our clinic every Friday when we have the severe asthma program, and they really interview these patients and families. They find all these legal needs for these families, their landlord issues, their adoption guardianship issues, their immigration problem, their school issues, you name it. When we get into their family situation, we find that there are so many different issues this family is going through. One of them is just asthma. So these lawyers really work with these patients and families and take care of these issues. That also helps so much for their asthma control. From the severe asthma program, we learned that you need a village to take care of this high-risk, difficult to control asthma patients. So here, I would like to talk to you guys about one of our severe asthma patients. We have 60 to 70 patients that we follow in our clinic. This is one of our severe asthma little girl, DL, 9-year-old African-American girl with severe persistent asthma. What does that mean? She was on this high dose of inhaled corticosteroid and the combination medication, but still her asthma was poorly controlled. She was getting several emergency room visits. She went to the ED prior to our severe asthma program, she went to the ED 11 times, 3 times PICU admission and 1 intubation. Kids admitted in the PICU, especially getting intubated, there is kind of a death sentence. It is really difficult. They can die from asthma. That is really sad because of all these medications and resources we have here. But the sad thing is, it is happening still. This particular 9-year-old girl, she was in a very difficult situation. She was exposed to secondhand smoke exposure. People living in the house, dad and mom, they were smoking inside the house. They were smoking in the car. She was very non-adherent to her inhaled corticosteroid LABA combination. She had severe allergies to dust mite. Her IgE was high, 389. And just like I mentioned, very difficult family situation. We tried all sorts of things. We started her on school asthma maintenance medication. But even if she's getting the inhaled corticosteroid and the LABA at school, she's coming back to the same household where she has so much triggers. So she was still going through all this tough time. So we had to go to the extremes. We moved her out from the biological mother. We had to go to 2 times in the court for this adoption process. This is before our medico-legal partnership came into play. Now the lawyers come to our clinic. Before that, we needed to go to the court. So for the past 2 years, her asthma is so well controlled. She didn't have any hospitalization. She only required 1 course of oral steroid. That was when she had a flu infection, viral infection, and she really needed to go to the ER and to get that course of steroid. She's now a normal 12-year-old girl, just like any other 12-year-old girl, running around playing tennis. And we could actually decrease the dose of her inhaled corticosteroid LABA combination to the lowest possible. And we even took her out from our severe asthma program. We say she graduated from our program. So this is one of our success stories. We have, just like I said, 70 to 80 these type of patients in our clinic. Here, we could actually give her the same medication, but better control when we control the triggers. But so many of our other patients, we needed to step up the therapy. We need to start the biologic medications. So we looked into our program, how we are doing with our program. This is like a really preliminary report that I pulled out. So you can see that since we started the program, before and after, how many emergency room visits. This is for 70 patients we have. Number of emergency room got significantly decreased. This is all for asthma emergency room visits. Number of hospital visits significantly got decreased. ICU visits same. Oral steroid the same case. Urgent care visits and PCP visits, that was not very significant. So we are doing pretty good with this program. It's not just one person's effort. Just like I mentioned, we do need a village to take care of these patients because so many people are playing a role for asthma education, giving the medication, and taking care of this patient population. Thank you. Now, I would like to introduce David Fedele. He's a pediatric psychologist in the Department of Clinical and Health Psychology, and he's board certified in clinical child and adolescent psychology. His program of research focuses on identifying ways to help families manage chronic illnesses like asthma. Today, Dr. Fedele will provide some strategies families can use to improve how frequently they take their medication. Thank you, Dr. Fedele.
Thanks, Sreekala. One moment, let me get my slides pulled up here. Okay, are you all just seeing the slides or also seeing the notes? I hope just the slides.
Just the slides.
Okay, thanks, Kathryn. Hey, everyone. Good afternoon. Thanks for the introduction, Sreekala. As she mentioned, my name is David Fedele. I'm a pediatric psychologist at the University of Florida and going to spend a few minutes today, maybe shifting gears a little bit in terms of speaking more towards families or community members, discussing strategies that we can use at home to take asthma medications as often as possible. So to start, I just wanted to acknowledge that taking care of asthma in general is really challenging. I think that's important to note. So families, individuals are asked to do a whole host of things to manage asthma, recognizing, monitoring symptoms, knowing and avoiding asthma triggers, and for many individuals, taking asthma medications every day, similar to what Sreekala was just mentioning. I'm going to focus on strategies that families can use to try to take preventative asthma medications, also known as controllers, inhaled corticosteroids, as often as possible. So examples of these medications might include Flovent, Dulera, Symbicort, Qvar, among others. These are, of course, different than the quick relief medications individuals with asthma take for immediate or quick relief of symptoms. Controller medications reduce inflammation in the airways and are often prescribed to be taken twice daily every day. In the asthma literature, taking medication every day as prescribed from a healthcare provider, even when you aren't feeling sick, is called adherence, is a term that's often used. If you found that either you or your child has some difficulties being 100% adherent all the time, you're definitely not alone. We know that primary non-adherence or not filling a medication that's been prescribed by a provider can happen in up to 40% of adults with asthma. And we also know that secondary non-adherence or having medication on hand, so the script's been filled and it's at home, but having difficulty still taking it consistently can happen in up to 70% of kids with asthma, so quite common. There are a number of benefits to taking these preventative controller medications as often as we can. We know that there's a positive correlation or association between controller medication adherence and these outcomes. So being less likely to have an asthma attack or experiencing impairing asthma symptoms like shortness of breath or wheezing, having better asthma control and quality of life, paying fewer visits to the doctor or hospital because of asthma, and missing less school, or work because of asthma, which can be quite burdensome, as Dr. Fishe was mentioning. So before launching into these strategies, you might be thinking about there's a number of reasons why an individual may or may not take their medications, and I thought this figure would just be helpful to sort of ground some of the conversation. So starting from the top, the opportunity to consistently take medications is not equally available across individuals and families. Having medication can only happen if a family has access to healthcare and they can access it. So they have healthcare near them and can access that healthcare consistently. This might mean having insurance, nearby providers with relevant asthma expertise, the ability to navigate a pretty complex healthcare system in the United States, reliable transportation, the means to attend and fill prescriptions. And so families who are socioeconomically disadvantaged or living in poverty do not have the same opportunities to have medications and access them consistently. We also know another big component of adherence is beliefs about health and medications. Those can influence how often we take controller medications. There are concerns about medication side effects that are well documented, preferences for alternative treatments or home remedies, understandable thoughts that preventative medications aren't necessary when not having asthma symptoms or difficulties with asthma. These are important areas that can be embedded in family and cultural systems. I want to acknowledge that and just mention sort of this context. I'm going to focus today and the remaining time on strategies to increase adherence in the context of more unintentional non-adherence or potentially with kiddos if they're refusing to take medications. So the first type of unintentional non-adherence or reasons for low adherence that's common is forgetting. Forgetting to take a medication is the most common, actually, unintended adherence barrier in the literature. So for those families who are with us or providers, even when working with families, if you find that you're forgetting or your child's forgetting to take medication as consistently as you hope so, there are a few things that we can try. First, and a go-to for a lot of us on the psychology side here is alarms. So almost all families have a phone that can be used as an alarm to help trigger a reminder to take the medicine. You'll want to set an alarm at a time that's typically convenient for both you or your child, and that you're likely to be near your medication. So you wouldn't want your alarm going off ideally as a reminder if you're away from the house or don't have your medication on hand. And I think it's important to be realistic with this. It's likely not to solve everything. And it's okay also to vary your alarm schedule. So if you're staying up later on the weekends or sleeping in later on the weekends, making sure that you personalize an alarm schedule is really important. Another strategy to think about using is cues. So one thing that's kind of cool is we can change our environment to increase the chance of taking medicines. So placing medicines where they're available and paired with an event. By that, I mean like placing medicines where you're going to see them, like near a toothbrush, or potentially where you're getting dressed in the morning, can prompt someone to take medicine because it's visually cueing to them. Over time, hopefully our hope is that builds a habit for families. And I think it's important to pick a medication and work through when and where to leave it, and make sure that the family is aware so parents aren't then going back behind the kid and cleaning up a medicine or putting it back in a medicine cabinet. A third strategy is using apps, which Dr. Blake is going to talk about next, so stay tuned. I think that's going to be really exciting to hear about. Difficulties with time management is frequently endorsed as another unintentional barrier to adherence. And by this, I mean a lot of families have multiple kids and are working, are fully employed, have other outside of work activities. So fitting in medication consistently can be hard. These medications don't take a long time to administer or take. However, I think in the context of a busy day, it can sort of go to the bottom of the priority list. So family problem solving is a flexible tool that can be used in a number of situations actually, but and for the purposes of this presentation, we'll talk about it with medication taking. And the way that I typically approach this with families is to first go over a few ground rules as we're going to work together as a group. So you would want to include both a child, if it's a family sort of environment, the parent, and any other family members that would be pertinent to the discussion. Keeping in mind that it's meant to be a collaborative sort of brainstorming process. We're not pointing fingers or blaming for not taking medicine as consistent as we'd like. Everyone's on the same team and we're working together. And trying to stay positive and team-oriented can really be helpful for people to share ideas. And then the process is pretty structured. So you would walk through problem-solving steps. There's many acronyms for this. I like the SOLVE acronym, which is selecting a problem, identifying options, having each family member rate the likely outcome of that option, choosing as a group the very best one, implementing that solution, and then evaluating whether it was successful or not. So the key here is to be really specific about the problem. So that would mean potentially taking medications in the evening, on the weekend, during sports season, whatever it is. Being really specific can lead to good success with this strategy. Feeling down, stressed, or anxious can also interfere with adherence. So I'm just going to briefly review some general wellness strategies that can be used as a way to tackle some of these concerns. One caveat is this is definitely not a supplement for clinical care if you're finding that you or your kiddo has symptoms that interfere with daily activities and are pretty persistent. So first could be scheduling pleasant events. So it's common for individuals who are feeling stressed, worried, or anxious to withdraw or keep to themselves more often. Life becomes less reinforcing or rewarding. So identifying and planning for engagement activities that you or your child will find reinforcing or consistent with their values can be really helpful. By positive activities, I mean things that you enjoy or like doing. I actually want these to be feasible and available to us. Think about spending some time to practice guitar, for instance, versus going to Disney or going on a vacation. And just brainstorming what these activities can be and being purposeful in terms of including them into your day-to-day life or your kids' day-to-day life can actually give you a mood boost and might actually reduce some of these things that are getting in the way of you feeling more demotivated to take medication as often as possible. Sleep is another essential piece in allowing our body and mind to rest and recover. So practicing good sleep hygiene, just as sort of FYI for adults, that's 7 hours or more. For teens, that's 8 to 10 hours. School-age kids, 9 to 12 hours, and preschoolers, 10 to 13 hours of sleep. Some few sort of just sleep hygiene strategies, going to sleep and waking up at a consistent schedule, making sure you have a consistent wind down routine before bed, avoid staying in bed when you're not sleeping, and limiting electronics for bed is a big one. Before bed is for kids. Third and fourth, I think having a good balance between being physically active, even in the context of asthma, and also planning relaxation activities can be really nice and restorative and help families maybe feel like they're able to overcome some of these symptoms of low mood that might be getting in the way of taking medications as consistently as they'd hope. And I have some handouts and I have my information at the end if people would be interested in these strategies with some more detail. And last but not least, we sometimes see treatment refusal, especially amongst kids and teens. This is basically kids saying, I'm not going to take my medicine, no matter what you say, mom or dad. I think with this, it's really important to keep expectations realistic. We're not going to go from not taking medication at all to taking 100% of medication all the time. But I really like to work with families on thinking about how we can use rewards and reinforcement to help with improving or shaping behavior. So for kids, this typically looks like reward charts where we're actually giving out points or stickers or some other reinforcing item or object to a kid contingent upon or reliant upon them taking the medication as we ask them. For teens, this can look more like a behavioral contract where we're working through with them and actually having them agree upon, if I take my medication this frequently, I will have access to this thing at the end of this time. Maybe it's a week, for instance. For the parents who are on the call, don't underestimate the power of praise and positive reinforcement in your conversations with your teens or your kids about asthma management. The more enthusiastic, the more encouraging we are in terms of their progress, the better. So here's my contact information. Thanks for your time and attention today. I hope you found some of these strategies helpful. It's a pretty brief review, but happy to talk offline with in more detail with anyone. Next, it's my pleasure to introduce Dr. Kathryn Blake. Dr. Blake is a pharmacist at Nemours Children's Health who has specialized in research on asthma in children for the past 25 years, and more recently researches the use of electronic devices and interactions to improve adherence to medications in children. Dr. Blake's going to share with you some information on some of the new devices today. So let me stop sharing. Okay. Welcome, Dr. Blake.
Thank you. All right. Now I gotta share my screen and make sure I'm sharing the right one. All right. So if you can confirm, oops, I think I need to switch, that you see the slides and not the presentation. If you'll just let me know.
Correct.
Okay, great. So like David said, I'm going to tell you a little bit about some electronic devices that are out there and then finish up with describing some ways that you can actually help advance asthma care and treatment by participating in research studies. So let's see. So there are a lot of apps out there on the Apple Store or Google Play that will help you manage your asthma, help you track symptoms, let you keep a diary, let you share that with your doctor when you take your phone in. This one also has like a link to inhaler videos where you can actually, if you don't know how to use your inhaler correctly, then you can go to some videos to get step-by-steps to do that. There's education, there's smoking cessation. So there are a lot of these out there. There's no way for me to tell you like which one is the best one, because that's really going to be kind of your decision about which features are most applicable to like you or your child if you're helping take care of a child. But there are a lot of them out there. New ones are coming out all the time. They're upgrading these all the time. So there's lots of options for you to pick from. Here's another type of device that's out there. This is a peak flow meter. And so it actually can connect to your smartphone. And then when you blow into it, if you blow into it, for instance, every morning before you wake up and before you take medications, it can track your peak flow scores over time. And then down here, they're like dates on the bottom. So you can kind of see what your trends are. And then all the information from like devices like this, because you'll purchase this meter up here, attach it to your phone. It's all stored on the phone. So you'd have to take it to your doctor. There may be ways to download it so you can print it and take it to your doctor, but then you can share it that way. Now there's some other devices like this, and I actually have one right here. This is the Spirobank Smart Spirometer. And a spirometer is really the kind of lung function that you do when you're at the doctor's office. And the difference between a peak flow is it just measures one aspect of your lung function, whereas a spirometer measures many different aspects of your lung function. It measures like how hard and how fast you or your child are blowing out, how long you were able to blow out, and it kind of gives the doctor a bigger picture of what your lung function is like. So for systems like this, they are Bluetooth paired to your phone. And so when you blow into this device, it'll record many of these indicators of your lung function onto the phone. And then it has an app, and it will tell you what your numbers are each day. It has a incentive piece of it so that it instructs you how to do the spirometry, just like you would in the doctor's office when they tell you to take a big deep breath in, blow out as hard and as fast as you can, and keep blowing, keep blowing, keep blowing, so you feel like you're going to pass out, but you won't. So then it'll record all this. Now, systems like this that are spirometers also have a dashboard that your provider can access. So something like this, your physician would prescribe for you if he or she felt like that this was something that was going to help you to track your symptoms at home. And it would be able to provide the physician with up-to-date, day-to-day information about how your lung function is doing. So certainly, as we heard before, for people who have severe asthma, this might be something that a physician would find would be helpful for monitoring your lung function. Now, a lot of these do require a subscription, and so it would also then depend on what insurance companies are willing to cover for this kind of care. But this is out there as well, and there are numerous ones of these as well. This is another kind of device. Now, this is a device, and this one's made by Propeller. There are other companies that are coming out with them, but this is a little sensor that can attach to your inhaler, and there are different sensors for some of the different devices. So if you're on a powder inhaler like a discus, they have a different kind of sensor that will fit on that, for example. And so this is kind of nice because it's what we call passively recording when you use your medication. So you don't have to input anything. So every time you use your inhaler and press on the top, it records that you used the medication. So it can record both your controller, like your inhaled steroid, or it can control your rescue, like your albuterol. In case you didn't know the difference between those two, your inhaled steroid is one that you're supposed to use every day, and then your albuterol is your rescue. And by tracking this, it helps your physician understand, if you're using your controller every day, but you're still using a lot of your albuterol, that there may be some breakthrough symptoms and maybe you need a change in dose or change in medication. But this will Bluetooth connect all that information to your phone as well as to a dashboard that your physician can see. And then it provides you with some reminders to tell you, oh, you're supposed to take your inhaler, your inhaled steroid at 8 o'clock in the morning, and if you miss it, it'll give you a reminder to do that. And this same software, the same app on your phone, will allow you to input information about your symptoms. So if you did use your albuterol, you could input that you were having coughing or wheezing or what sort of symptoms you were, and that also can be helpful to your physician in managing your asthma with you. So here it will give you feedback based on your medication use, and sometimes they'll ask you questions about your asthma symptoms on particular days and give you a score. So in this case, the person is kind of having a medium day, so it's a fair day for their asthma. It may give you weather forecasts or pollen counts depending upon the different apps and things like that. And then it can also connect to pharmacy information if needed. And so then this is like a big picture like that your physician might see, so it can give a sense of like how well controlled you were over the last 30 days, how many days out of the month you were well controlled versus not so well controlled, if you woke up at night and things like that. So a lot of information that your physician can get. And again, this is real time. So as soon as your phone and your device connect by Bluetooth, then that information is stored in a dashboard your physician can access. So this, again, is just another way to look at it. So this person used rescue inhaler uses on all these days, and these were the days that they used their inhaled steroid. And as you can see from what David was describing, like adherence wasn't up here at 100% for their QVAR, their controller medication. But it gives you that feedback, like, oh, yeah, I am missing a lot. Maybe that's why I'm using so much albuterol. This is another new device that just recently came out. So not only does this have a sensor in it to track each time you use the medication, but it also can give you feedback on whether you inhaled it correctly. So for instance, if you didn't inhale hard enough or fast enough to get a dose that would go into your lungs, it would tell you and give you that kind of feedback. So this is like another kind of generation of how the inhalers are being developed to try and really optimize the way that you use them to make sure you are getting the medication into your lungs. One of the disadvantages is that you may only have like this particular inhaler or another inhaler that fit with this kind of device that would tell you whether or not you were doing it correctly. One of the other ones that I showed you kind of fits on many different inhalers with those sensors. But this has that advantage that it'll give you feedback on how well you're doing with inhaling. So there's some other work that's being done at Apple where they're looking at, for instance, the Apple Watch to see if maybe that can help predict when you're going to have an exacerbation. So it may track your sleep cycle, like David was talking about, if you're not getting enough sleep, or how active you are. So if suddenly you're not doing so much, you're not going up the stairs as much as you would on a normal day, or you're just not going outside, those are the kinds of things that these data may start to track. And we're doing research, I'm not personally, but research is going on to help understand maybe wearing a watch like this might help be a predictor for somebody who might be having an exacerbation. And again, that might be helpful for people who have really severe exacerbations, so cause them to wind up, like you heard earlier, in the ICU, or even have a tube down the throat being intubated. And then there are devices that can measure the indoor air quality. As you heard earlier, if you're exposed to secondhand smoke or other things in the home, you can track that too. There are a lot of these. You can buy them on Amazon. I can't tell you which ones are particularly good, but they do also track to your phone, so you have that information on your phone. And then it can pull other information like pollen counts. But a lot of times it may not be pollen counts that are right where you live, because these are centralized pollen counting centers. So for instance, last time I checked, like our closest one for Jacksonville was down in Daytona, because it takes a lot of effort to track pollen counts correctly. So it may not be exactly locally where you are. And then lastly, this is really cool. So these are silicone wristbands, just like you see people wear for other reasons. But what these are collecting the chemicals that you're exposed to on a daily basis. So you might wear it for 3 months or something like that, give it back to the researchers. This is for research only. And then they grind it up and they can measure all the chemicals in it, and they can see, oh, wow, you're in an area that has a lot of diesel particulates or something like that. And those are the kinds of feedback that may help you to know why you may be having symptoms in a certain, around your home or something like that. So this is for research only at this point. So how can you help advance asthma? By participating in a research study. Probably the biggest source, if you haven't heard of this, is clinicaltrials.gov. So for the past several years, every research study that meets certain criteria, meaning that patients are prospectively randomized to a treatment, has to be inputted into clinicaltrials.gov. And so you can then see what might be available in your area. And I just plug this in. For example, I'll put asthma in children as a choice around Gainesville, Florida, and if you'd be willing to travel 100 miles to be to a research study. So then you can search and you can see everything that's coming up at that point. You can also go, and I went to UFHealth's website, you can also go to an institution's website. And so when I searched for asthma, you can see the different ones that are coming up for airway diseases, and go to your institution to participate. And then, for instance, the American Lung Association has research studies, so you can also look here under asthma and look for research studies being conducted that may be in your area as well. And then CenterWatch is another place you can go that also has a lot of research studies listed, and then you can tailor that search so that you can find things that are in your area. And I think that's it. So thank you.
Great, thank you, Kathryn. That was wonderful. So we have had some questions in the chat, and I'll just start with the first one that came in. So someone asked, what else can they do to help their son who has asthma? It's the most difficult time of year, and I assume the person means because of allergies and the sort of temperature swings we're having. So would anyone like to take that question?
I can do that. So I'm just wondering what all things you are doing at this time. You are exactly right. This is the time of the year that most of our asthmatics have a lot of trouble. So, just like Dr. Fishe was talking about, the viruses are there. And this year, because of maybe with all the COVID precautions and everything, now it's kind of losing up a little bit. We have the RSV season starting. So we are getting a lot of RSV infections now. And so many other viruses. So respiratory viral induced asthma exacerbations are more now. And then pollen count is really bad now. It's getting a little better now. But so I'm wondering what treatment he or she is getting. The son, I think, yeah. So we do need to really tighten up the maintenance medication, because just like I mentioned to you before, that asthma airway is really inflamed. And if there is any trigger getting into that airway, there can be severe exacerbations. So if you want to go private chat, I can do that, but we do need to really go into what all steps we are taking now. And then what is the step-up medication that we do need to add into the asthma medication, or do we need to go with biologics? So there is a stepwise approach that we go for asthma management. So if you do need any private help, I can definitely do that. We can see the patient, your son in the clinic. It's all happy to do that.
Thanks. And I also can add that there's some research I've done, which was a large statewide database with many people from all over Florida. And as the heat index rose for Caucasian children, actually, their risk of having an asthma attack went down. But for most African-American and most Hispanic children, as the heat index, so as the average temperature went up, their risk of having an asthma attack actually went up. So that's some more personalized information. And as we know, not everyone experiences everything quite the same. Sreekala, I think the next one was in reference to the study you published about the severe asthma clinic. It was asking what your study sample size was for that publication.
Oh, thank you. That is the study about school asthma maintenance program. And we started with 49 patients, and 40 patients completed the study, 40 children.
Great. Yes. Okay. And the next question we had is vape smoking as harmful to children as cigarette smoking?
I can take that question too. Yeah, we have so many of our patients, in the hospital. Vaping is a new epidemic, right? We all hear that even from middle school and high school, definitely. So I would say vaping is even harmer. It is more harmful than cigarette smoking. We know a lot about cigarette smoking and what tobacco can give to our lung, how much harmful effects. We know that if cigarette smoking, the tobacco can decrease the sensitivity of the inhaled corticosteroids. So inhaled corticosteroids won't be as effective if you are exposed to tobacco smoking. So we know a lot about cigarette smoke, but we don't know a lot about vaping. But we are seeing a lot of patients with vaping-induced lung injury, and some of them even requiring lung transplant, that level. So the problem with vaping is like, what is the ingredient in that vaping material? We don't know. They can add anything into that. So those ingredients can be really harmful, not just for the lung. It's a lot of brain damage also happening. So it's a lot of literature coming out from the vaping injury. So I would say vaping is more injurious than cigarette smoking, mainly because we don't even know what the ingredients are and what are the long-term side effects from vaping. We don't know. Jen, if you want to add anything into that.
Yeah, I can actually from the emergency room perspective. Unfortunately, this is an odd thing to say, but I think regular tobacco products are more regulated than these new vape products. And so there are many children who intend to vape nicotine, which is the main, active ingredient in most cigarettes. And like you said, they end up purchasing something that's very different. And we've had some children end up with overdoses of not only nicotine, but other illicit or even illegal substances who didn't intend to go that route. And we have to see and provide emergency treatment for them. The other danger is kind of a secondhand injury from vape pens, because it's a very concentrated amount of nicotine that goes into a vape pen. And sometimes little toddlers find the cartridges that are loaded into the vape pens and drink that nicotine. And that's actually a fatal dose of nicotine for a toddler. And so unfortunately, that's also a possibility with vape pens. Whereas I don't think in my career today, I have seen a toddler eat a cigarette. So, you know, there's secondary consequences of these new devices that we're only beginning to learn. And unfortunately, they all are very harmful. And I agree with your assessment.
One thing to add is from a parenting perspective, we've been involved in some research that shows harm perceptions around vaping are lower. Parents perceive, and the community perceives, you can kind of see this, you know, out in your community, with people are more willing to potentially vape freely than they are smoke cigarettes. There's less regulation around vaping as there is smoking traditional products. And so we've seen a little bit of an uptick in terms of caregivers being more free in terms of exposure to kids of secondhand vape than cigarettes. There's less public health messaging about vaping. It's unregulated, like we've just mentioned. And so in turn, there are some families that will vape around their kids as it's harmless. And I think a takeaway is that it's definitely not harmless. We don't know yet about sort of long-term implications, but it's not likely to be anything positive. And so thinking about if you're going to vape as a parent, or there's someone in your family who's vaping, sort of exercising the same caution, especially with a kiddo with asthma, in terms of being around them infrequently, not exposed to that, to breathe in from a secondhand standpoint, is something else to just throw out there to the audience.
Great. And the next question, I believe, is for Kathryn, talking about all the really cool devices and apps. The attendee asked, is there a way to connect this to EMR records? And EMR for folks is electronic medical record. So the computer record when you go to the doctor or go to the hospital.
So that's a good question. And the disappointing answer is not regularly, not with these devices. The problem, and that is a big problem, because as I showed you, one of the dashboards that the physicians would access, that means they have to go into their EMR where they'd be writing down their discussion with you and things that you're sharing with them. Then they have to go to a different dashboard and see, okay, what your inhaler use has been or what your spirometry has been from home. And there is not a way for all that to talk together. I know we're moving in that direction, but it's not there yet. And so I can't even tell you off the top of my head if any of them do interface. And they're different electronic medical records. Epic is one of the big ones. Cerner is another big one. There are a couple of others. So different physician practices may use different electronic records. So I know these companies have not been working with a lot of the smaller companies, but I do believe like some of the bigger ones used in medical centers like UF, or our system like Nemours uses Epic, for instance. That's one of the big ones. So that's where these device companies are going to target first. I don't know, David, if you have anything to add in your experience.
Yeah, I haven't seen direct Epic or EMR integration for those same reasons, and I think it's that's the future. And there's also been some, excitingly, I think, from the healthcare provider end. I think there are also some new CPT codes that providers can use that actually provide reimbursement to providers for doing remote patient monitoring of things like adherence. So when I've talked to some of these device companies, they're enthusiastic that might be another sort of way in for interested consumers, patients to use these. Providers would get reimbursed for their time if they were spending that outside of the encounter looking at a third-party system. So we'll see how that ends up.
I see this as a huge opportunity for actually our attendees to advocate for something like this. right now there's some connection to research platforms, but like Kathryn and David were saying, not to the main electronic interface we use clinically. But many of you, when you go and have a healthcare encounter, receive a survey afterwards asking about your encounter. How was your provider? Did they listen to your concerns? And then usually one of the last questions asks about sort of the health system in general and how you felt, you know, your care and all your care needs were met. And that is a great area where you all as healthcare consumers and the custodians and guardians of your children can say, you know, I love my asthma doctor. I really wish my home spirometry connected straight to her records. And, you know, us on this panel, we can do all the advocating that we want, but hospitals now are really listening to their consumer satisfaction. And I think that's a great opportunity for you all to advocate for actually getting these really interesting research advances into everyday clinical practice. All right. And we have just 3 minutes left and we have one more question. So I think this timing's working out perfect. So someone asked,
there's one in the chat too that I hope we can get to.
Okay. Are there any journals, logs that you suggest for people without smartphones or access to mobile apps?
Yes, I was going to just show, am I showing my screen, like asthma journal?
Yes, yes.
Okay, so for that individual, this is the Asthma and Allergy Foundation. I didn't go through this. I was just looking really quickly after I saw your question. But the Asthma and Allergy Foundation may have some logs that you could print out. The other place to look is the National Institutes of Health, and specifically if you put in the National Heart, Lung, and Blood Institute or just search for asthma on this website, you may come across some other places where you can download forms. Here's the American Lung Association again. You can go there. They may have some forms. And here's an example. I think this was on asthma.com. And so this is where you could print it out, and then it gives you a doctor discussion guide. So I think that if you have access to a computer, there are lots of places where you can look and you can find a form that maybe works for you best.
Great. And then David, are there any easy breathing materials that folks could use?
Those are more at the provider practices that are using easy breathing. Which I know is some of our UFHealth and the surrounding area clinics are doing that. And then I know Kathryn can maybe speak to this more within the Jacksonville and surrounding area. There's a number of clinics who are enrolled in that as well.
Yep.
Great. Well, we're right at 1 o'clock. I'm sorry if we didn't get to every question, but thank you all for your participation. Thank you to our panelists. Sarah will send out some more information about the town hall, and also if you'd like to contact any of us. I know my email is public record, so if you Google my name, my email pops up pretty quickly, and feel free to email me with any questions. And again, appreciate everybody's interest.
So Jen, just one thing. The last question was, is it safe for people with asthma to get the COVID vaccine? So I think that's a really simple answer.
Oh, yeah. I will let you
go ahead and answer. The answer is yes, absolutely. We strongly encourage you to get the COVID vaccine if you have asthma.
Great. And then someone asked if there's a publicly available resource guide. I know the American Lung Association has a lot of resources on their website. Mm-hmm. So I would definitely recommend that everyone check out that website, ALA. All right.
Thank you all.
Thank you.
Thank you.